My name's Andy Reamer. I'm going to use they, them pronouns today. I'm a consultant at SidePorch, where we work with good people who are trying to do hard things that make a difference across health, education, climate, human performance, but providing that emergent operational and long-term strategy support. Work across sectors and types and work best with people and organizations that are trying to do something new. Whether you're a startup, a fund, a large organization, doesn't matter to us. But I'm really excited to be here today, and I'm really grateful for SOCAP for giving us this space to talk about this really important topic. Before I introduce our speakers, I want to give a little bit of context. So we've been hearing this throughout SOCAP, but we stand on the unceded territory of the Ramaytush Ohlone. They are traditional custodians of the land, which was forcibly taken from them, without disregard for their humanity, community, culture, and relationship with Earth. And in addition to that, colonialization added this imposed concept of time, of time is money, and linking morality and economic value to the punctuality and productivity of our world. If you want to read more about this, Bay Area's own Jenny Odell's book, Saving Time, is a very interesting piece about our relationship and history with time. And throughout SOCAP and really my life, I've been struggling with this concept of disentangling what is urgent and what is a priority, especially to create systems change in our limited time together. And so I believe this challenge to be of disentanglement to be an existential crisis of our life. And when everything is urgent, how do we prioritize? When we are in a mental health crisis that will cost $1.3 trillion per year between now and 2040, how do we prioritize? And so today, our panelists will illuminate their process and suggestions for prioritization based on underscoring the challenges of today, illustrating hope for a more just future, and sharing some case studies of success and progress. So we have some incredible people on the panel today. You can read about their amazing bios on the Brella app and on LinkedIn. And I'll ask them to introduce themselves as they answer this first question. We'll just go down the line to start. But the first question: what do you see as the biggest barriers to creating a more cohesive mental health system, and how can we overcome them to better serve vulnerable populations?
Great. Thank you for that question. Well, first, I'm the Chief Operating Officer at Didi Hirsch Mental Health Services. I've been there for 22 years. And what we do is we provide comprehensive mental health, substance use, and suicide prevention services, especially in communities where injustice limits access and discrimination limits access. So that's our focus and something that I'm personally very passionate about. So thank you for inviting me to this panel. So my perspective on answering this really comes from that. It's rooted in the fact that I'm a psychologist by trade and a mental health provider and someone who provides at our agency a continuum of services from prevention, intervention, postvention across all age groups. And the biggest foundational must-have that I'm seeing right now that is somewhat urgent is the lack, or it's something we have to conquer, not something we must have, is the lack of mental health parity that exists. It has a huge impact on the workforce shortage and on finances. There's an access issue. So, obviously I think we would all agree that one should be able to access mental health services as easily as they can get their broken leg fixed, but that's not the case. Right now, most people have insurance in America, but only about half are accessing the mental health services that they need. And some of that's related to the workforce shortage, which is related to rates, where, it's hard to access it. Some of it has to do with more systemic issues, such as lack of coverage or delays in coverage. In fact, we provide something called safety planning in our suicide prevention services, not covered by insurance. So for us, that's a big deal. And the issue around mental health parity and being able to get access and rates the same as physical care is very intertwined. The rates right now that we receive are completely unsustainable, which is also why we have a workforce shortage. So it's all very intertwined. And for us, I just want to clarify, to put a finer point on this, there is a mental health Parity and Addiction Act law that was passed in 2008. But I can tell you firsthand, it's absolutely not enforced. And, we're providing something within our services right now called enhanced care management. And it's a Medi-Cal service that's covered. And the whole idea behind it is to take the high utilizers, the people that use all the systems the most, and have the most complex issues medically and mentally, and really wrap them around with services of all types. And we're getting paid on a per month, per member rate. And it sadly, it's a great idea, but it seems that the payers and the rates are actually dictating what we're able to do as opposed to what the needs are of the client. So honestly, in my mind, I'm very grateful for investors. We're desperate for that in the mental health world because it is a true tragedy and travesty, in my perspective, that we have to rely on philanthropy in order to subsidize health insurance coverage in America for those who need it the most.
Well, I'm in violent agreement with that. Not much to add. No, but hi, I'm Andrew. I'm Andrew Barr. I'm one of the founding partners of a firm called GreyMatter, which is a specialized fund focused on mental health, brain health, all these related issues, right? And I got into this work after a career in more traditional tech. Due to my own experience with OCD as a kid, and I was one of the lucky few to get treatment, and that's a 1 in 20 type of outcome that I got. It's the only reason that I'm sitting here, and so I have a lot of gratitude for that. But when I think about what's broken with this system, I think about my own journey, and I was lucky enough that I happened to have great parents who were paying attention, but they didn't know anything about mental health. They didn't know anything about the healthcare system in general. Right. And we just happened to get really, really lucky. The first therapist that we found was an expert in OCD and was using what are now gold standard evidence-based treatments. So that's like, let's call that like a 1 in 20 or 1 in 10 type outcome. But then those treatments happened to work for me too, right? And that didn't mean it was immediate. It was still a journey, and it's still a journey, right? It's not like it's not like even like fixing a broken leg. These are chronic conditions, right? And so, but I was lucky enough to get that support when I needed it, and it absolutely altered the trajectory of my life. The other factor though that's important there is that they were able to pay for it out of pocket. It wasn't easy for them to pay for, but there was no insurance coverage, and they were actually advised by the therapist not to do that because it would become like a pre-existing condition and you wouldn't want insurance to know about it or whatnot. And that's like just wild to think of. And I think we've made progress here. But ultimately, to me, the biggest barrier to change here is the way in which we pay for mental health care and what we choose to pay for and not pay for as a society, and what the business models around that are. And a lot of our work is trying to find creative business models that align the interests of the patient, obviously, and getting the right kind of care, but also look at the system as a whole and say, how can we do this efficiently? How can we meet the needs of all the parties involved, knowing that we have a massive workforce shortage, for example, and that there's no way to provide enough, one-on-one psychological counseling, let's say, to treat everyone who needs it. And so, trying to find that in my mind, so much of this is the aligned incentives and then bridging that gap with innovation, new kinds of solutions that serve the needs of people who frankly just can't otherwise get that help today. And so much of our work at GreyMatter works with these more vulnerable populations where there actually is that alignment. You can go to, let's say, a Medicaid managed care organization and say, this is actually a big problem for you from a dollars and cents perspective. And I'm always biased towards trying to rely on people's financial incentive rather than their goodwill. It's great to have both, but we're trying to find situations where people will act, even if it's not something they have to personally care about.
So there's not much left for me or Aaron to say. I'm Dr. Charmain Jackman. I'm a psychologist, child and adolescent trained, and forensically trained. So I am the founder of a company called InnoPsych, and our goal is we're focused on inclusive mental health solutions. And I'll share a little bit more about that. But I'll share a personal story. In 2017, my marriage was on the brinks. And my husband, who's also a Black man, we were looking for a therapist because we really needed it. And we were both clear we wanted someone who was Black. It would have been great if they were from the Caribbean because that's where we hail from. And we had the hardest time. It took over 6 months. I'm a therapist, right? So you'd think I would know. It would be easy. It was not. There was one main therapist directory, and when I put in Black or African American, a whole bunch of people popped up that didn't look Black or African American. And then I was like, okay, well, let's go to the insurance. So we went to the insurance and we say, hey, we're looking for therapists. Can you help us? And they sent us a list, a 5-page list of people's names, phone numbers, and address. That was it. Not helpful at all. And so I'm like, this is not well. We found one woman, a white Jewish woman. She said, call me in 6 months, and if I have an opening, I can see you. And we called her in 6 months because we couldn't find anyone in that time. So my company focuses on people of color because we are looking for people who, we're highlighting people who can provide culturally affirming care. That was part of our journey, right? It was very important to us. We didn't find that, but she did well. And we're still married and going well. You know, it's married, so we still have a lot of problems, but but Andrew, and I hope we can have a brave conversation in this panel. I know you said you were lucky. I don't think it was necessarily luck because the system was built for white males, right? So I did not, we were not lucky. I guess we were to use that paradigm, right? So, it's very important for me. And as I, in my company, we focus on two sides. We're helping to educate people of color, understand why wellness and well-being and mental health is important. But also we're looking at the therapists, because in the mental health industrial complex, we do not center people, the patients, or the providers. And you've all hinted on the workforce issues, but the providers are stretched to the max. Many are not trained to serve diverse clients and patients. And so they don't want to go see a person who will not understand their cultural background. So to me, those are some of the barriers that we're facing.
I agree. I will see what I can add. Hi, everyone. I'm Erin Seatstra. I'm the head of investments at Hope Lab. We are an organization with the mission of improving the mental health and well-being of teens and young adults, with an emphasis on young people from underserved backgrounds. And we do that through impact investments, which I lead, as well as research and translational science. I think two barriers that I would add, and they're sort of nestled within each other. One is the system as it's designed today has so much friction at every point. And I'll use an example based on young people just because that's our focus. But say you're a young person who is struggling behaviorally. It is very possible your parents don't know how to recognize those signs or know where to get you screened. Maybe it's a teacher who identifies an issue. Even getting you screened, there's friction. Then you're screened and there's a question of, okay, now where do we go seek care? Maybe you find a provider, they don't take insurance or they don't take Medicaid. And then maybe you find that provider, you've somehow found a provider who's covered by your insurance. You can access it, you can pay for it. And there's no therapeutic alliance because they don't understand your lived experience, your family context, or often with young people, you want to treat the young person. You also want to be able to sort of counsel their parents and their trusted caregivers to ensure that the environment around them is one that is conducive to mental well-being. Good luck getting that paid for, right? If it's, it's one thing to get the actual patient paid for, but then moving to sort of their concentric circles around them. So there's all that friction within the system today. And even if all of that was fixed and moved smoothly, we wouldn't be addressing the larger problem, the bigger barrier, which is that a lot of these mental health challenges are actually caused by social issues. It's economic strain, it's not feeling safe in schools, it's increasingly climate change for young people, it's gun violence, it's sort of this world that's built around all of us where it's actually quite understandable why anxiety and depression are so high when you think of all of the pressures and sort of obstacles that are just getting in the way of thriving. And so even if we had a fantastic mental health system that was frictionless, it would still just be sort of downstream addressing the immediate problem rather than sort of also going upstream and addressing some of those larger systemic factors. And so, Andy, to your question around sort of what's urgent and what to prioritize, I unfortunately want to say, like, yes, all of it, do it, please, which is obviously not prioritization. But I think there are the challenges with the system and the challenges with the world, and it's hard to disaggregate the two.
Absolutely. And that's why collaboration is so key, because we as individuals can only prioritize so much, but to know and look over our shoulder and see other people working towards that, of the systemic inequities that infect us on a daily basis in the air that we breathe through racism and misogyny that impact the ideological and the institutional and the interpersonal and our own internal work. All of that is a constant motion. And I appreciate everybody's vulnerability in sharing their journeys and what they are seeing as the challenges. And so as we think, we've seen the challenges, we've talked a little bit about the challenges, the immensity of these challenges, thinking about the future. What is this hopeful future that we're looking for? How do you envision innovative care models reshaping mental health service delivery to reduce fragmentation? And maybe I'll skip over and start with Dr. Charmain Jackman. You have Innovate in your company's name. What are you seeing? What are you hoping for? What are you illustrating as you think about the vision for a more just world?
Thank you. So there comes, if we think about we see a lot about upstream. And I think, again, as we center people at the margins, I think education is a key piece. And working in schools, Erin, I saw a lot of that, right? Families who were very hesitant to engage in mental health services because of medical mistrust, which comes honestly. And so a big part for me and my company is around education, shifting those narratives about mental health, changing that stigma. And we were doing research on just some of the attitudes that people have, some of the childhood messages that they've received. And I would say we found, overwhelmingly people have either negative or judgmental perceptions about therapy and mental health. And so it's really about education. And in the schools, we actually did a great job in providing a mental health curriculum for our students, which really helped our students then became our referral system. They would refer their friends, they would bring their friends. If they saw students post potentially suicidal thoughts on the social media, they would come and tell us, hey, my friend posted this. Don't tell them I said it, but can you help? Right. So I think that education is a huge piece. I think also what I found in my work in the schools and the work that we do at InnoPsych is partnerships. So a lot of the work that we did in the school-based work, we didn't rely on insurance. We had a partnership with Children's Hospital, and we partnered with universities who provided interns, so we provided training for them. So those collaboration models are really important, but I think it also lets the insurance payers off the hook. So they also need a part in that system too. So, and I would say even though for the work that we provide in the schools, even though we were a really well-resourced school, we could never meet the need of our students, of all the needs, right? And our families. So I think when I think about innovative models, particularly in the realm of young people, we have to include families, we have to have partnerships, and we have to have community-based organizations as part of that curriculum as well.
I would piggyback on just this idea of collaborative care, and I think it can happen in a number of ways. You talk to a lot of pediatricians who are increasingly learning how to recognize signs that a young person needs mental health support, and then they're running into wait lists. They're running into sort of challenges of getting them that care. And I think there are opportunities to train people to go a little beyond their current purview. So, we're not expecting pediatricians to become therapists, but to have them have maybe networks of coaches or peers that they can tap into in the short term as young people or their families or patients in general are seeking that longer term care. Being able to train guidance counselors to be able to sort of tap into community resources in a way that, unfortunately, it puts a burden on providers that are already stretched really thin. And the reality is we don't have more providers right now. And then I think technology plays a really big role in that. Being able to allow people to refer to a wider range of providers, not as geographically constrained as who was in driving distance. Being able to tap into things like CBT curricula that actually can be done more asynchronously than necessarily requiring one-to-one therapy. Being able to tap into virtual groups, peer support. I think that in order to be able to address some of these challenges, you need to have that cross-pollination of specialties, and some of that happens at the individual level of sort of being able to dip a toe beyond what you were specifically trained initially to do. But there's also a piece around technology that enables you then to tap into specialists that do exist and that may have availability, but that otherwise wouldn't have been on your radar if you're just relying on the resources that are available in your community. So I'd like to see us reducing some of that friction, at least by training the providers who do exist to be able to bridge those gaps a little more seamlessly.
I agree about technology, but I'm going to let Andrew answer that one. It's more his domain. But I also agree about partnerships and how we approach the counseling and the therapeutic work that we provide. I think what's integral is that we're providing whole person care. We can't just address certain aspects of somebody. We have to address their mental health, their physical health, their substance use needs. We have to make sure that there's no wrong door. If they're walking into a primary care physician, they're being assessed for depression. If they're coming into my community mental health center, they're being assessed for diabetes. We have to do that. We also have to assess for social determinants of health. The health-related social needs that one has, where they grew up, their zip code, whether there's community violence, whether they have housing, things of that nature, it counts for 80% of one's health outcome. It's nothing to do with their actual health. So first and foremost, I would say whole person care. The second thing I would say along the lines of partnerships is whole system care. We absolutely have to work along a continuum and to have seamless transitions, but we also have to work in partnership with other systems. Mental health care is not just an issue for insurance companies or for health. It affects all of us, and it affects all kinds of systems. So, for example, one thing that we're doing right now is we're partnering with the LAPD. And when calls come in to 911 and it's determined that the crisis seems more mental health oriented, the call gets diverted to us. We have the largest 988 call center in California. So the call gets diverted to us. And I'm, proud to say that we're able to de-escalate 85% of those calls. So police do not even have to go out into the field. And we also know that for every $1 spent on community mental health, it saves $12 in criminal justice. So we really need to be thinking more systemically about how we can be approaching this and involving other systems as part of the payments, which brings me to my third thing. So value-based care has been around for a while in the medical field, less so in the mental health. And I feel very strongly that we're already going that way, but we very much need it to go that way by 2030. Otherwise, we're incentivized to just provide the service and have high volume versus incentivizing us to meet the outcome, have the impact, have the performance, make sure that we're doing what we need to do. That helps the individual, but all the systems, both financially and socially. And social impact bond models is something that's newer to me, being that as a provider. But I've learned a lot on this 3-day conference. And when I hear that, I get so excited because I'm like, that is what we need more of. We're running a transitional age youth wellness center right now. And the whole point is to take these youth between the ages of 15 and 25, many of them aging out of foster care, and wrap services around them of any type. Because we know, by the way, sad statistic, 1 out of 4 foster youth are going to be homeless by the time they're 25. We're trying to prevent that. And so whether they need housing, mental health services, a meal, trying to help them find employment, getting them in college, we are going to do that because we know we're going to prevent ED utilizations by addressing physical care. We're going to keep them out of the jails. We're going to keep them housed and just have a much larger impact on systems. So I know that was a long answer. I get very excited about my work. So.
I mean, that's very, very comprehensive. I think we've covered a lot of it. I mean, I guess the only thing I'd build on here is where you left off on value-based care. And one of the most interesting things to me is that if you were a therapist, right, and you had the perfect therapy, you could sit down with someone for a mere 5 minutes and you could cure whatever mental illness they had, right? Just bear with me for a second. That would be a terrible business in this current structure that we're in. I mean, you wouldn't have any patients coming back. You'd be getting paid for one session. That'd be the end, right? Like it wouldn't work. And I think it's just like a thought. I mean, obviously that's provocative. It's extreme, right? But I think there is a big problem in a system that doesn't necessarily incentivize results. And it's kind of a simple idea, and it's something that maybe sometimes when you're like knee deep in the world of healthcare, we kind of forget about that. Like other businesses rely on the the satisfaction and goodwill of their customers. And I think that, for me, what gets me most optimistic and what we're seeing happening already, and many times, as I mentioned before, with more vulnerable or marginalized populations, actually, we're able to find those value-based care models where a provider, like often a company, and sometimes they're using technology, but I'm not a believer in technology for technology's sake, right? Like there's no extra points for using technology in this space. It's about the outcomes, right? But we are seeing a number of companies that we've backed, probably half a dozen or so in our portfolio, that are using value-based care arrangements and then using technology to actually deliver the outcomes that these people so desperately need, right? And I think that's what makes me really optimistic is when you can get enough dollars so that the companies and the organizations that are actually able to deliver better results more efficiently are able to reinvest those profits into growing and ultimately serving more people. Like I think that's how this most optimistic version of capitalism would work. And, doesn't always not trying to paint too rosy a picture. I think it doesn't generally work out that way. But if there's something that I'm really optimistic about, it's in that lane. When I think about 2030, what I hope we're thinking about next is working. Today, we're talking a lot about, and one of the reasons why there's an opportunity for serving more marginalized populations is because there's a lot of cost associated with emergency department visits, inpatient stays, other even criminal justice, right? And that's in a kind of dark way is where the opportunity has been created. And I think it's incumbent on us to try to serve those populations as we can there as a field. What I want to make sure, though, kind of back to some of the things that Aaron was talking about, is in 2030, hopefully we're thinking beyond that. We're thinking about what else do we want to pay for as a society? Because one of the problems in the youth mental health field, for example, is that kids are pretty healthy and the comorbidities are pretty limited, right? And so ultimately, you have to have children with extremely high acuity mental health problems to see that show up in meaningful healthcare costs for you to then go after some kind of value-based arrangement against. And so we end up with this problem where kind of mild to moderate, even more extreme mental health problems, using myself again as an example, it didn't show up in any other kind of healthcare costs. It wasn't like my insurer would have said, oh yeah, Andrew, we could have we would be happy to pay for your expensive OCD treatment because it's going to save us money over here. Which wasn't the case. And definitely not on a 2-year actuarial timeline. But when you look at the broader picture of my life, that's probably a decent investment for the government to hold on to at some point in time. On there.
Thank you all so much for all of those insights. I'm thinking about the full spectrum of mental health, and this is a term that is extraordinarily personal. When we say the word mental health, it is almost like saying the word diversity or equity or inclusion. We each paint a picture in our own mind, often dictated by our own personal experiences or those close to us. And I think that's a really interesting framing of where we want to be heading towards in the future when we were thinking about things more collaboratively, when we were thinking things outside of our own self and maybe and centering those that are most marginalized and oppressed by the current systems. The full spectrum of mental health makes me think about meeting Dr. Charmain Jackman for the first time. I think it was 7 years ago at Boston Arts Academy. Yes, I think it's been that long, maybe more. I don't know. It was amazing to see Dr. Charmain working and seeing the way that young people trusted her and the relationships that you had with the educators, where they could also come to you as well as the peers. I also think of a nonprofit called the Mustard Seed Generation that went to the rural South, where they worked with pastors who were serving multi-generational Korean families, and the pastors were working with counselors and better supporting those communities. I think about Laura's work here in the front of modality and thinking about paraprofessionals and the under-tapped resources that paraprofessionals can provide in that space. And so as we think about the process to go from today and the challenges and injustices that we pointed out today and the future that we're hoping for, I'm hoping that you all can share some of your work that has been successful in bridging these gaps between the different parts of the mental health system to provide more coordinated care, and what are some of the key factors that made that integration possible. And I'll start at the end with Aaron, partially because one of the reports that just came out of Hope Lab utilized some of my PI's research focused on social media and suicide prevention. But I'd love to hear more of what's coming out of Hope Lab and what you've seen as success stories.
Yeah, very happy to. And I will start with an example of one of our portfolio companies, which is actually one we share with Andrew and GreyMatter, a company called Flourish Health. They provide virtual care to young people with serious mental illness. That's bipolar, schizophrenia, young people who have been discharged from the hospital or the emergency department and need ongoing care. And to your point on value-based care, the reason their model works is because they have been able to work with Medicaid plans to get a bundled payment to do what it takes to help that patient. So it's not we get paid per therapy session and therefore we will only do therapy sessions. They're doing therapy, they're doing psychiatry, they're doing peer support for the young person, parental support for their parents, they're collaborating with schools as needed. And the only way they're able to do that is because they have the flexibility in the way that they're paid for them, for the team, for the care coordinators, the doctors, the people who actually understand the case, to be the ones making the judgment about what will help that patient and that family, as opposed to just being tied to do the things that they can get paid for. So it can be really limiting living in a fully fee-for-service environment where, again, you're not only just doing the things that get paid for, but you're probably prolonging them because you get paid for them, even past the point of efficacy. And so I think that's an interesting model where their care coordinators are also tapping into social services, also addressing those social determinants of health, and they're really able to do so because they were able to find some innovative payers who were able to take that kind of risk. And so my hope is that once you have a few proof points that this can work, they can then go to more payers. You can have more companies that are replicating that kind of model. But I think that's an example of where you're seeing more of that cross-functional care that's actually working. And then, Andy, just to your point around sort of some of the research that Hope Lab is doing, we every 3 years do a national survey of young people looking at their habits with technology, their habits online, how they're thinking about mental health and well-being. And something that I actually find gives me a lot of hope is that young people, particularly Gen Z and now the upcoming Gen Alpha, they are talking about mental health. They care about their mental health. They are supporting their friends. It is no longer sort of something where people, I mean, I say this as a gross generalization. A lot of people are still sort of in stigmatized communities and are suffering without support. But this is a generation that has really made it clear that mental health is something that they care about, that they're going to demand resources for. Not all of those resources are going to be in the healthcare system. A lot of it is through community, through online spaces, through sort of being able to better lean on their peers. And I will say, I am a parent to young kids. They're 1 and 3, and honestly, my hope is that social media doesn't exist by the time they're teenagers. I know that's not going to happen. But the truth is, the teenagers we talk to, they don't want that. They say, we understand the risks, we understand the challenges, but also social media provides these critical spaces for us to find identity affirmation, for us to find community, for us to find resources when we don't feel like we have access to them. And so I think we often and rightfully focus on the negatives of social media, and there's a lot that we can do to make it safer for young people. But I also think it's really interesting to see how online spaces, even in a self-directed manner, have become really important tools for well-being, and for us to understand that not all of mental health care is going to happen in a clinical or even a virtually clinical setting.
Okay. Well, I think I mentioned before that we have one of the largest and most comprehensive suicide prevention centers in California and the nation. And we've been providing crisis care continuum services for over 80 years. But sadly, for the longest time, the funding for it was incredibly unstable. We had to piece together funding from some of the counties that were willing to kind of pay for it. And we didn't know if there was going to be a budget for it the very next year. So to us, it's like, wait, we're providing a suicide prevention hotline service and nobody's stepping up to fund it. So for us, part of how we help bridge gaps was really, we built a crisis care consortium in 2014. And ultimately what we did is we pound the pavement in Sacramento. We testified in the Senate and Assembly and did everything we could to advocate for funding. And ultimately, we did secure for a little over $4 million for the California crisis call centers. And subsequently, it turned into what's now called 988, which is for suicide prevention and mental health. And we were asked to be the leads for California because of the pounding that we did, and we knew we could do it. And luckily, it's more on the up and up in terms of funding, and there's now getting crisis care continuum is getting a lot more attention than ever before. But that was only possible because of extreme perseverance, a lot of advocacy, a lot of reputation building, a lot of partnership building, a lot of collaboration, and a lot of strong data where we could show the ROI that we're saving lives, preventing people from having to go to the hospital, preventing law enforcement from having to go out. So for us, that was a big success. But right now, we're trying to take it a step further. We've been quietly behind the scenes trying to create a kind of a comprehensive suicide prevention care center where we've been testing new models of care that we know work. And right now, we provide kind of a one-stop shop and a blueprint for what we feel works as a safety net when someone's either not in the hospital or someone's not making a phone call. And what we do is we provide extensive training and outreach. as well as intervention for those who are at risk for suicide. We provide specialized bereavement groups for those who have lost someone to suicide. And we created our own, now empirically based, survivors of suicide attempt group curriculum, which most people run from. But we took on that liability for obvious reasons, for the care of the clients, but also we know that those who do attempt suicide are at extreme risk. So we have an opportunity here to prevent it from worsening. So we were lucky. We received a transformational gift from Mackenzie Scott a couple of years ago, but we're still in a place where in order for us to test these models and to really scale, we have to continue to, pound the pavement and get investment in this, since we know it works. We know it works, and we want to be able to provide a service that is less costly and less restrictive than ultimately inpatient hospitalization. So for us, I think the gap bridging was really around working with the government and working with other providers to really try to bring in the funding needed for something that's incredibly life-saving.
I mean, there's so much in that, right? And I think it's amazing work that you're doing, and it's, I think in so many ways, like, is emblematic of what's possible with grant money and public sector money to actually help prove out models before they're ready to be commercialized, and scaled in, more of the kind of for-profit context that we exist in. I mean, one area that we're optimistic about, and something that's been exciting for us, is that, broadly speaking, in this space, the bad news is, if you look at the public health data, like, it's all very bleak, right? It's bad across any dimension you want to cut it. It's like there's very few places where we say, "Wow, mental health, it's really working now. It's great." Like we're on the way. It's going to be fine. On the other hand, if you're the kind of person who wants to solve problems and make this space just a little bit better, there are so many opportunities, right? And kind of the joke, I had a family friend over for dinner the other day, and she was like, how do you find opportunities in mental health to make things better? And I was like, actually, that's the easy part. It's like there's so many opportunities. If I figure out how to get paid for them, okay, it can get more complicated. But there are lots and lots of things we can make better. An example where we've worked in this area of crisis care as well, and building on the work that many nonprofits have done, looking into what do you do to prevent somebody from being strapped to a gurney in an emergency department for 72 hours, right? That is not a therapeutic experience. It is not optimal in any way, shape, or form, and it's quite bad for the ultimate outcomes in the system. Even if you didn't care about the patient, which we obviously all should, it's really, really terrible for the system. And so, we saw when you get closer and closer to these problems, as you get deeper and deeper in this space, there are $100 bills just lying on the ground. You just need to be close enough to see it and to see where the opportunities are and see where the funding gaps are. And so, we were fortunate enough to be able to partner with an entrepreneur to stand up a new company focused on emergency department diversion and crisis care, and essentially bring people, instead of having them stay in the emergency department, being able to bring them into more soothing residential facilities, imagine kind of townhomes, right? Where somebody can come in the facility is, sure, there's a little bit of clinician supervision, but mostly run by peers, people with lived experience who've also experienced maybe psychosis or suicidality or other, whatever this person is struggling with, right? And allowing them to come into that space and kind of regain their balance, right? Instead of sitting with these fluorescent lights above them, strapped to a gurney for 72 hours, it turns out, unsurprisingly works, saves money in the system. And in certain states, if you know where to look, there's actually strong Medicaid reimbursement for that. And so that's an example where, I get really optimistic about the fact that maybe we can't solve all the problems today in one fell swoop immediately, but there are lots of places to make progress as we go, year over year, and we just keep, as we get deeper and deeper into this work, it's almost like it keeps fanning out the number of opportunities that we're seeing, and that makes me optimistic.
All right. We only have 4 minutes now. There's so many things, I think. So I'll start with the school base. I think, we're seeing more and more schools have trained social workers in the school setting, I think, which is great. I think one of the roles that I played when I worked in the schools was reducing students having to go into the ER, right? Because like you're saying, that place, it's never a good outcome. They're there for hours. and then they just get really pissed off having to be there, right? So that doesn't work. So the more that we can divert young people from those settings, I think that was really helpful. We also partnered with a company, organization, the Brookline Center. They had a model, building resilience for youth in transition, which was a program that supported young people coming out of the hospital. Because what we would see is, because of our limited resources, the students would come back, they'd go right into the regular schedule, and within a week, they'd be back into the ER. So that really helped to put more services in schools and then reduce their rehospitalizations, which was really powerful. Another model, I think, we're seeing around social prescribing. So kind of expanding what that therapeutic intervention look like. It doesn't have to be in a therapy office. So using arts and creative works as a way to help people maintain their mental health, right? Because you see your therapist maybe once a week. What happens the other 6 days, right? So that's a great model we're seeing. And some insurance companies are actually paying for people to access arts in community. I think the other piece around, there's a model in Zimbabwe called the Friendship Bench, which uses grandmothers as mental health care resources. And I think that's a really great way to bridge our generations as well, and give a sense of purpose for our elders in our communities, and decrease loneliness. So I'd love to see models like that here. And one last thing I was going to say. So yesterday I was at a workshop, and there was a woman who has a company called Kismet Health. And their model is, which I love, she said, Zoom was made for meetings, not for therapy. I was like, yes. And so they've created a model that's focused on engaging with young people through tech, which I think I think that's a great model, because I always worry about. And when I worked with students during COVID, it was the worst thing to use Zoom to have a therapy session. It was really awful. So I think my last comment, and then my last piece is, as we continue to look at the therapy lens, I always want to lift up the providers in this space. And so part of my work is providing education and community for therapists, because we cannot ignore them in this space. And so that's a lot of what we do, working on their their own self-care, but also their business practices. And my last comment is, I think that as we think about tech and solutions, including tech, we cannot ignore that our solutions must also be human-powered.
Well said. Thank you so much. So we're about to start the Q&A session. If you have questions, please write them down. Paluk over here has cards. As we kind of gather those, I'll mention 4 more kind of case studies that I'm very excited about and happen to be involved in. One is Teen Line. Teen Line is a part of Didi Hirsch. I sit on the board of Didi Hirsch. I was the previous board chair of Teen Line before we got acquired. We've been around for 42 years, 4 hours a night, haven't missed a night. We're a crisis call center run by teens for young people. The average age of a young person calling in with an active suicide need is 12 and a half, and it highlights the kind of crisis that we are at. On the research side, I was just able to be of support to Georgetown University, where they relaunched a new center called the Thrive Center for Children, Families, and Communities, building on 60 plus years of amazing research, but also seeing that it takes 17 years on average for the best practices in family mental health to actually be implemented in the field. So they have added on a new innovation hub that is going to bring in startups from frontline entrepreneurs, nonprofits, and for-profits to bring them closer to the research and to the practices in the field to kind of accelerate this whole movement going forward. Climate Mental Health Network just did a nationwide survey on Gen Z. Approximately 4 in 10 respondents indicated that their feelings about climate change impact their self-reported mental health and ability to function daily. And 85% of those respondents reported being worried about the impact of climate change on people and the planet. And more than half of those respondents really just wanted to talk to somebody about it. They didn't feel like they could talk to anybody, their parents, their grandparents, their educators. And so the Climate Mental Health Network is providing those services and supporting educators in being able to talk more with the young people. The last thing is a fund called Cure Health Fund. They're mobilizing philanthropic and impact investment capital to support frontline entrepreneurs to lift new solutions that can realize exponential access through generative technology by centering humans in communities that need it most. And they're focusing on the three most underfunded sectors: women's health, aging health, and mental health, to try to reverse that. So as we get into these questions, I am very interested in saying this. Okay, so we'll start with this one. Where is the investment energy in the mental health space? What are the gaps in your portfolios that you are looking to fill? And maybe, Andrew, we'll start with you, and then we can also talk from our own personal experiences that's trying to raise for money as well. But
yeah. So the question, just to make sure I heard it correctly, was where is the energy in the investing field, and what are the gaps in our portfolios?
That's how I understand it, yes.
Okay. The energy is always sort of shifting from place to place, right? And I think there are almost like little mini waves within it. When I would say, like, if I was going to zoom out, there was, call it early in the pandemic, 5 years ago, there were basically no mental health unicorns, right? $1 billion plus companies. Through the pandemic, a number of employer-focused ones rose up. Companies like Lyra Health, Headspace Health, Modern Health, Spring. And those companies essentially were selling mental health as an employer benefit to large employers. That was net positive in many ways, got more people access to mental health care, but it created a different problem, which is it sort of put the scrutiny on payers, on insurance companies, as to why they weren't able to provide this benefit for those same employers who they were theoretically serving. That led to the rise of companies like Headway, Grow, Alma, Rula, Sondermine, and that's kind of the next generation of mental health unicorns. Those companies were essentially like network businesses or marketplace businesses that connected. There's sort of three sides, right? You've got a patient coming in looking for therapy, and they're connecting essentially a network of therapists, but they're also bringing in the insurance companies, right? And basically, so you can go on and you can say, okay, I'm looking for a therapist, hopefully with a number of terms that you're looking for. Who knows if there will be availability, but it's easier than calling 5 pages worth of people, hopefully. And those therapists will be in network with your insurance company, right? So that's kind of the next wave. Now, you could see both of those waves as essentially like different versions of aggregation and access, right? And access to mental health treatment as that being, covered mental health treatment as that wave. I think what we're seeing happen next in the field, and where I think the momentum is going, is towards quality and outcomes. Because if you are sitting in the seat of a mental health payer, since the beginning of the pandemic, you've increased your mental health spend, right? This entire bucket of spend on mental health by somewhere between 30 and 110%, which is massive for a single category, right? If your cardiac spend went up by that, people would be like really blown away, right? And so that's led to the kind of countervailing push of saying, okay, well, we're starting to pay for a lot more things, but are we paying for the right things, right? Are we getting outcomes? And so I think a lot of the momentum in this space is, and to some degree, where we're always looking for more companies, are companies that have found some way to deliver better outcomes in a really, in a kind of value-based or value-driven framework. And that could be for any number, and that's led to a number of specialized companies. We have companies in our portfolio that focus on pediatric serious mental illness, that focus on adult serious mental illness, right, going at risk. We have companies focused on PTSD for women as the audience, rather than like veterans is often the audience that people are thinking about when they think of PTSD. But for women, it's much more common. Actually, the population is much larger of women who've experienced domestic violence or sexual assault than there are veterans. And so that's sort of, these kinds of specialized companies are where we're seeing a lot of the energy going in the space.
And if I can just add maybe a gap, and I don't know the answer to this, and I don't know if, Andrew, you're feeling this. You're talking about waves. We, over the last 5-ish years, had a huge wave of companies that are using teletherapy in some way. It works really well, and I'm finding myself craving what's next. I still get pitched teletherapy companies, and there are varying reasons you would do that, but I'm kind of like, yeah, you're a little late. Like a lot of investors have made their investments and they're now thinking through, okay, what are the complementary investments that we can make as we're building out a portfolio? And so I'm finding myself sort of holding my breath to see what that next wave will be. At this point, AI is table stakes. Everyone talks about it. They mean it in different ways and use it in different ways. I am not yet at a place where I think, AI can replace a human in terms of delivering mental health services. And I do think that there are ways where we're talking about sort of provider burnout, we're talking about administrative burden, we're talking about better diagnostics. I think I'm curious to see where those kinds of technologies actually drive meaningful outcomes versus where they just sound like a good idea. And so I think we're in that sort of prove it out period. And I'm hopeful, if a little skeptical, that we'll be able to see some sort of meaningful areas where technology can move the needle in addition to sort of creating this better access and outcomes.
Absolutely. And the next question's for Charmain and Kristine, but I wanted to add to that there is an interesting parallel to the decarbonization world where there is an overinvestment in EVs, despite it being a smaller percentage of carbon in pollution. That's similarly with therapy. It's the most tangible thing that we can grasp, but there is so much more when it comes to the definition of mental health. So that leads me to questions, Charmain and then Kristine. What are some of the preventative care initiatives that you're seeing out there, especially those that take into account intersectionality and social justice looking upstream? I know that you do a lot of work with workplace wellness, for example, but what other preventative care models are you seeing show up in the field?
I mentioned it earlier, the social prescribing, where we're seeing payers, insurance companies paying for providers to prescribe an arts experience for their clients. I think that, say the question again.
What are you seeing in regards to arts mental health is a great one, but right. In preventative care, looking upstream, what's the energy that you're seeing? What are some exciting insights that you're seeing?
Yeah, I mean, I think lift up the providers in this space. I think we're seeing a lot of energy around therapists really being mindful about what does their work-life balance look like. You talk about provider burnout. I think that is a huge issue that we're looking to solve. And I think providers are being, setting boundaries around their work. And so I see that as a place. I would love to see, in a lot of the work, I'm actually serving on the American Psychological Association Mental Health Tech Advisory Committee. We make fun of APA. It's my organization, but this is the first year we're having this advisory committee. So we are way behind. And I think one of the things I'd love to see more is how can mental health professionals actually be at the table as we're creating and thinking about technology or what does the field look like? So I would like to see energy around that. How do we even create a fund that helps therapists have space to innovate and create? Because we're in our offices, we're doing the work, which leaves a little time to have that creative, that vision in. So I'd love to see action around that.
I think, it's. I love the question because a lot of money right now, especially with California with Prop 1 passing, there's more focus on prevention, housing being one and prevention being the other. And we also know that suicide among youth has been going up exponentially in a scary way. I think the most recent study that came out, at least in California, is 1 in 3 high school girls are seriously contemplating suicide. As a parent, that scares the crap out of me. So there has been a lot of focus, thank God, towards youth suicide prevention services right now and teaching youth to be there for other youth, because that's where they go. Not necessarily, I mean, yes, there's teachers and there's adults, but if we can democratize the prevention by teaching in schools youth how to be there for another person and recognize the warning signs, that's going to get us a lot further, I think. So that's where I'm seeing a lot of attention going right now, and as it should.
Wonderful. I think we're almost at time, but I wanted to end with one last question. Because mental health is so personal to us, I've been struggling with suicide since I was 12. I've been seeking out and trying to figure out how to support others in my life. A big piece of the radical work that we can be doing is finding joy in our own life. And so I'm wondering if we can start with Erin and work our way back this way of like, what brings you joy on a daily basis?
Okay, what brings me joy? I mentioned I'm a mom to 2 young kids, and toddlers are just hilarious and surprising. And so if I'm ever sort of down in the dumps or feeling daunted by the work that we're doing, my children will inevitably find some wacky way to cheer me up, whether they mean to or not. And I'll sort of click up, which is that I just feel really encouraged by young people in general, by the upcoming generations. We spend a lot of time talking to and listening to young people, and they are so clear-eyed and passionate and really able to advocate for themselves and their generation in a way that I certainly didn't feel I was equipped to do at that age. So I feel hope that the young people have a lot of drive, and I hope that we and the systems don't take that away from them.
So I'm a parent of 2 teenagers. They do give me joy sometimes. But I'm definitely so I transitioned from working as a full-time psychologist in a high school with teens to being a full-time entrepreneur. And that was intentional for a number of reasons. I had reached a stage in my career where I wanted to do something different with my brain, but I was also pretty burnt out. And so the joy is actually for me rediscovering myself and challenging myself to do things that terrify me. So traveling, I've gotten back to traveling. Whenever I go to a new place, I do something that's a little scary because it helps me to reconnect with who I am. So and just helping people to reconnect with their joy. So I do that a lot. And I have a TED Talk. If you're interested, check with me, and I talk a lot about my journey about finding joy.
It's such a good question. And I think that sometimes we get like really in the weeds of just doing whatever it is we're doing. And so like, and trying to make whatever impact we're trying to make. And you can kind of lose sight of the joy in it. I found my daughter is also a grounding. I have a like roughly 1-year-old, and she's like mastering the words no and bye-bye, much to my amusement. Like using them in times where sometimes it's very fitting, but not what I would have wanted her to say to me at that moment, So we have fun with that, and it is totally grounding. I think for me in the work, so much of what brings me joy is meeting people who have that entrepreneurial optimism and that drive to just change this space. And it usually comes from personal experience, and it's like deep inside them, like they need to get this out. And it's frankly just so much fun and really inspiring to be able to work with these people and support them. It's getting to know them, understand where they're coming from. It's just a lot of fun. Yeah.
I have to also say my children. I have 12-year-old twins. I mean, it depends on the day.
I guilted you into that one, Kristine.
That's true. I was complaining about them earlier. But sometimes they bring me joy. Outside of that, honestly, it's the work that I do. Even though I'm kind of, up there in the administrative level trying to figure out how to make these, systems work and whatnot, I make a point to go and see at the ground level what's happening. And I walk over to our, transitional age youth center, and we see kids, young adults, that's between 15 and 25. They're all kids to me now. I guess I'm getting old. But who walk in and don't have a place over their head, a roof over their head for that night. And I see suddenly the whole team rally around this person, and they'll stay all day and night until we find them a roof over their head at night. And that is the stuff that brings me joy. That is why I work buco hours, because I can see the direct impact on the kids and the adults that we serve.